Donata, the floor is yours.
Okay, thank you, Clementine. Good morning, everybody. I'm delighted to join this discussion of the COVID-19 mental health, taking forward the lesson learned. I am Donata Meroni. I'm the head of unit in Sante, dealing with health promotion and disease prevention and financing. This webinar takes place on the EU Health Policy Platform in the framework of the COVID-19 Mental Health Support Stakeholders Network. You may remember that this network, quite valuable, was set up by DigiSante in May 2020 in order to support the efforts on the ground of social and health stakeholders, encourage them to discuss and share information on COVID-19 and related mental health issues, and to develop a set of guidance documents that can help address the mental health aspect of the COVID-19 pandemic. I would like today to give you some highlights of what the EU is doing on mental health and peculiarly on the impact of COVID and what has been done with the EU countries. You know very well that in the early stages of the pandemic, non-COVID-19 outpatient care and hospital care was suspended or slowed down to reduce the risk of transmission and release capacity to avoid the risk of critical care being overwhelmed by COVID-19 patients. This led to major disruption in the normal flow of patients through the healthcare system. Primary care and chronic care for patients with non-communicable diseases were disrupted and transformed to protect staff and patients from infection, notably through the use of teleconsultation when possible or other digital tools. As many interventions were postponed during the peak cycle of the pandemic, waiting times for elective surgery and cancer care increased significantly in many countries. As of May 2020, the European Commission has initiated various activities to address and mitigate the mental health impact of the pandemic. This included setting up a dedicated network space on this health policy platform to facilitate the exchange of expertise and practice by stakeholder organizations, as I mentioned, and as this is the case. And we organized also on 6th of May a high-level conference on COVID and mental health. I also would like to thank Mental Health Europe for their role as coordinator of the health policy platform network community on the mental health impact of the pandemic. They are here with us and they are very precious contributors and cooperators. The Commission also rewarded community-based initiative alleviating the mental health impact of COVID-19 via the 2021 EU Health Award. Several projects to implement promising practices to reduce the mental health impact of COVID-19 will start later in 2022. I know that some organizations have participated and submitted their proposal under the annual program 2021 of the EU4Health program. I have to tell you that the evaluation has been finalized. The EU budget contribution is about 1 million, has been increased, and quite soon the relevant organization will be informed and will be invited to start the grant agreement preparation, as we say in a technical jargon, and to start working before the end of the year, the real work on the field. In the field of mental health at work, the Commission is working with the European Union Information Agency for Occupational Safety and Health, we call EU OSHA, to ensure that the protection of worker health makes an integral part of the OSHA's initiative related to preparedness plans to prevent a future health crisis. In 2021, the Commission adopted a communication on a EU strategic framework on health and safety at work 2021-2027, which includes a number of initiatives planned in the area of mental health related to digitalization and in particular the right to disconnect and during teleworking. In addition, the Commission invited member states and social partners to take action in this area. I would like to mention also, even if it's not strictly related to COVID-19, the action that the Commission is carrying out concerning the impact of war in Ukraine and on mental health for displaced people in Ukraine, also in the EU member states and Ukraine neighboring countries. The Commission so far has mobilized over 11 million euros from the EU health program to help people fleeing Ukraine in urgent need of mental health and trauma support. The EU signed a contribution agreement with the International Federation of Red Cross for the provision of quality and timely psychological first aid, mental health, psychological support to persons fleeing Ukraine and the ones that stay in the country. At this moment, it is being implemented in Czech Republic, Hungary, Poland, Romania, Slovakia, and Ukraine, and we plan to expand again the action in other EU countries where Ukraine displaced people are. The main beneficiaries are children, older persons, people with disabilities, caregivers, and also health professionals and first-line responders. The support is provided in person, online, and through other platforms according to the country context. The Red Cross also cooperates, collaborate and coordinate the mental health activities with all relevant partners at the field and country level. We are working on the potential to top up this project to extend activities to other countries that are also receiving displaced persons. Ukraine displaced people are also the focus of a call for proposals from non-governmental organizations for best practices to improve mental health and psychological well-being in the migrants and refugee population. And I know again that some of you have participated, and now we are evaluating. The evaluation is ended, and the invitation letter have been already sent, and the project, the grant will be signed soon, and the work is expected to start in autumn this year on the field. We would like also to inform you that the Commission is cooperating with the OECD on the upcoming Health at a Glance report. And the next report will be issued end of November this year, beginning of December. And this report contains thematic chapters on disruption of non-COVID care services during the pandemic, also looking into workforce exhaustion. And a second focus will be on the impact of the COVID-19 pandemic on child youth health, including impact of disruption in mental health services for students and young people in schools, university, and the community. Primary care, specialized mental health care. So I would invite you, to follow this report and to be ready when it will be issued at the end of November. other
Thank you very much, Donata. I'm afraid
yes.
that we are running out of time already.
Yes,
We
just
have very much to change that.
I wanted to say you that I'm very pleased to be here with you. I give you the floor, and I hope that it will be really a fruitful discussion.
Thank you very much. So thanks, Donata. I'm Claudia Marinetti, Director of Mental Health Europe, and I will be moderating today's session, which is why, unfortunately, I had to stop Donata, but I think that there is so much that DG Santé is doing in the field that, of course, she had much to say. So thank you again. Thanks also for allowing for this group to be created in the EU health policy platform. So just very briefly, I will tell you what is the structure of today's event. What we will want to do, we will hear about what were the lessons learned on the mental health impacts of COVID-19 as identified by WHO. And then following this, we want to look into how these lessons have been taken forward. And so we will hear about some good practices, some promising practices in three specific lessons and areas. And we will also close into looking ahead, how to use the learning from the whole COVID situation in the context of other crisis preparedness and response. I will stop already here, and I would like to give the floor to our first speaker, which is Ledia Lazeri, Regional Advisor for Mental Health at WHO, the Regional Office for Europe.
Thank you, Claudia, and good morning, everybody. Thank you very much for inviting me, and especially thank you for taking this initiative on discussing the mental health impact of COVID-19. Without further ado, I will go to the presentation. I hope you can see. Claudia, can you confirm that you can see my?
It's
Thank
good.
you. Thank you. So what I'm going to talk is about the results of the work done by the Technical Advisory Group mobilized by the World Health Organization European Office since the beginning of the pandemic. The group was tasked with examining the data and evidence that was being produced along the pandemic advancement, and the results are therefore presented in a brief that is now online, but I'll also be happy that the organizers shared those slides with you. So what do we know? Prior to COVID-19 pandemic, we had already a very high burden in the WHO European region. More than 16% of the population of the WHO European region were already suffering from, were living with a mental health and substance use condition. And I want to make a point here that the WHO European region is larger than the European Union. We count 53 member states in our region. That includes all the Central and Eastern European countries, including the Central Asia. So the 53 member states represent the diversity of nations that represent also very different socioeconomic situations, and therefore the response to COVID has also been nuanced in between those countries. Going back to what we know happening prior to COVID-19 pandemic, I started to talk about the burden. I mentioned the number of people, but also economically, to the EU alone, this economic cost amounted to 600 billion euros. That was equivalent to 4.1% of the gross domestic product of the collective member states of the European Union. However, we know that the only minority of people with such conditions were receiving treatment of care, and coverage of interventions to prevent these conditions from arising or to promote mental well-being and resilience was negligible. So in other terms, most of the funding goes to curative services. Very little goes to public mental health interventions, those that are aiming at preventing and preventing mental health conditions and promoting health literacy and promoting good healthy behaviors in mental health. So this was already happening before the pandemic. Now, during the pandemic, let me see why. During the pandemic, what we saw evidence that proved that was an increased population level of mental distress. We saw increased mental health conditions and drug use. We saw increased risk of developing a mental health condition following COVID-19. So if there were people that were affected by COVID-19 infection and they were at an increased risk of developing a mental health condition, such as, for instance, an anxiety disorder or depression. We saw an amplification of risk factors for poor mental health and well-being, and we talk about that in a minute. We saw that particular groups were disproportionately experiencing mental health impacts associated with COVID-19, including from quarantine and lockdown. And we saw, as mentioned by my esteemed colleague before, a significant disruption of public mental health services all across the European region and larger in the world. So again, I have difficulty. Okay. So in more details, what does that mean? What did we notice? What the evidence shows? We saw increased rates of mental health conditions at the general population level. And we saw that prevalence of mental distress and mental health conditions increased following COVID-19 outbreaks, and as well as the introduction of public health containment measures. So it means that when lockdowns were introduced, the mental health conditions and mental distress increased. But then those reduced during the reopening phases. And that is very important to notice because it means that the population mental health follows the public mental health, health measures, the response to pandemic. We saw very interesting data on how overall smoking rates reduced and slightly more people reduced than increased alcohol consumption, contrary to the expectations. It was an expectation that at the population level, alcohol consumption and smoking rates were increased. We didn't see that. However, we saw a trend of increased drug consumption. We also didn't see evidence of increased suicide during the pandemic, although there are some studies that have suggested an increased suicidal ideation, suicide attempts, and self-harm. However, it is worth mentioning here that the pandemic impacts on suicide will have to be seen longitudinally. So we will learn more if post-pandemic suicide will be on the rise or not. So we are still not yet out of the woods in terms of evidence on this. Now, which were the particular groups at higher risk of mental health impacts? You will see that some of those groups were already vulnerable before. Now, people with pre-existing mental and physical health conditions or disability. Certain ethnic groups, they were already vulnerable because of stigma and discrimination against some minorities, such as migrants, refugees, certain ethnic groups in our region, and certainly the LGBT communities. But we also saw new vulnerabilities arising. We saw healthcare workers, like never before. Healthcare workers were subjected to incredible burnout and stress, and therefore started to display important levels of mental distress and mental health conditions. But we also saw an increase of risk in children and adolescents and younger adults, as well as in women and carers in general. People that imagine, for instance, if someone is caring for a person with a severe disability, of a severe illness, and how the lockdown and the impossibility to reach healthcare services or other support systems, what is the strain imposed on a carer, for instance. Now, what did we see? What was the impact of COVID-19 infection on mental and physical health? We saw that being infected by COVID-19 increases the risk of developing mental health conditions, no? And we saw that people that were infected by COVID experienced subsequent prolonged symptoms of mental ill health. And then you are aware that we are now talking also about the long COVID. We know that people with mental health conditions are at almost double the risk of COVID-19 infection and associated mortality. Everybody that lives with a mental health condition or with a person that lives with a mental health condition, they know how more exposed are those people because of poorer infection prevention and control, for instance, in certain facilities and so on. Quarantine and lockdown resulted in relatively small mental health impacts that reduced as the quarantine period continued. However, being a woman, being younger, having a pre-existing mental health condition, having lower educational attainment and lower income, and living alone or with children increased the risk of anxiety and depression. Risk factors for mental health and substance use conditions impacted by COVID-19 include socioeconomic issues, and of course you would imagine here inequality, poverty, debt, financial difficulty and recession, job insecurity, work-related stress, unemployment, reduced working hours, food insecurity, and all the rest. For the sake of time, I'm not going to mention them all, but you can read on the screen and you'll read when the presentation will be shared. However, there is hope, because we can see that there are protective factors for mental well-being and resilience that are impacted by COVID-19, and those include social interaction, employment, and physical activity. So one of the lessons learned here for the next crisis is that we need to maintain social interaction, we need to secure employment, and we need to maintain a physical activity. Yes. What was the impact on public mental health services? Programs for mental health and substance use conditions were the most disrupted. We saw how COVID disrupted the public mental health services in many countries of the WHO European region, and included closure of services, reduced staffing, and fewer patients accessing care. Many countries repurposed healthcare staff to frontline, including mental health staff, for instance, that meant that less staff was available for people living with mental health condition and substance use disorders. We saw that prevention and promotion services were most severely affected, and we saw that additional government funding for mental health and psychosocial support were fully allocated in only a minority of countries. So that means that funding for mental health services was at risk. And I see Claudia, I know that I only have 1 second left. Just give me, yes. 50, yes, my alarm is screaming. So how to address that? This is a list of the recommendations that were developed by our technical advisory group. So first of all, we need to have access to the culturally adapted evidence-based interventions. So we need to have culturally adapted evidence-based interventions. We cannot afford to have every Dick, Tom, and Harry going into the populations affected and introducing non-evidence-based interventions, including innovative digital tools, because that is at risk for patient safety. Psychological support initiatives in the workplace, because as we have seen, workplace became a very important locus for maintaining mental well-being, addressing the social determinants of mental health, including poverty, unemployment, socioeconomic inequalities. And for the sake of time, I'm not going to the overall list because you will read, but I want to mention here the importance that we learned from COVID-19 pandemic of including mental health, making it an integral part of emergency preparedness, response, and recovery plan. And that became that recommendation was verified when the war in Ukraine started, and we saw how important was that mental health was integral part of the government's responses in all the countries that were already mentioned for in this context. With this, thank you very much for having invited me and for giving me the possibility to introduce the WHO perspective. Thank you.
Thank you very much for this thorough and really very interesting presentation on all the lessons learned and what we need to do in the future and what we need to pay attention to. in case people have questions, Ledia, I'm not sure whether you can stay until the end of the next presentations. We will have a Q&A session at the end of the presentations, but please, if you do have questions, that's great. So write them already in the chat, and then we will look at them. So as speakers present, please already type your questions there. And I've seen already some people were asking where their presentations will be made available. Yes, they will be made available on the health policy platform so that you don't miss any of the very interesting details that our presenters are sharing with us. So now we pass to the second section of this event, which is looking into how the lessons learned have been put into practice. So we're going to look specifically into 3 of these lessons learned. And the first area is ensuring a living and working environment that is positive for mental health. So we will have 2 speakers, and I will give the floor to Felix Polinsky from the Trimbos Institute. Felix, the floor is yours.
Thank you so much. I'm also very happy to attend today and give you this presentation and kick off this section of the webinar. So indeed, I'm from the Trimbos Institute, which is the Public Health Research Institute, the National Institute for Mental Health and Addiction in the Netherlands. And since I only have a little time, I'm gonna start right away with what we're doing internally at Trimbos. So within our structure, we really have 2 out of the 6 dedicated core topics that target mental health of young people. And as Lydia already mentioned rightly, in the COVID or after the COVID pandemic, young people, adolescents, students were really one of the specific groups that were most affected by lockdown measures, etc. So we have 2 core topics, youth mental health or youth well-being and mental health and prevention, that really target this. With all the core topics that we have, we take a life course approach, which means that we look from different perspectives onto these topics, onto mental health throughout the lifespan. And since a year, and also because of the COVID pandemic, we have a project group on student well-being, which really bundles a lot of experts from within our research institutes to work on different projects related to this. And one, I think it's very small, but one is also developing reports which advise government, policymakers, etc., on the mental health of students. What we also do is we developed and evaluate interventions, and they usually take a more integral approach to mental health. So we have, for instance, the translation would be happy lesson or well-being in school. Those are really interventions that are generated or geared towards creating a resilient student or a resilient environment and a healthy school climate for students, prevent depression, and also bundle knowledge on mental health promotion for policymakers, end users, etc. This is also nicely reflected in the policy developments that we've seen in the Netherlands, which I think mirror also a lot of other countries. There's definitely an increased focus on young people. And in the Netherlands, we saw that there's been a national education program set up, which really bundles knowledge on everything that is related to education. And we have, since this year or starting next year, also really dedicated mental health policy, which is called Mental Health for Us All. And if you can see, the pillar 3 of this policy is geared towards a healthy education system. This slide is a bit messed up, unfortunately, but what we really advocate for is an integral approach. So rather than having individual interventions, we'd really advocate integrating them into an overall approach. And since my time is running out, I'm giving the floor also to Thrive Amsterdam, which is a really beautiful example of one of these approaches. Thank you.
Thank you very much. And I think that our next speakers, Tan Zwemmer and Thijs de Jong, can take the floor.
Yes, thank you very much, Felix. Good morning, and many thanks as well for this opportunity. We would like to touch upon, well, we call it a success story about preventive support on student well-being and national student engagement. And we're also calling for European action. My name is Teun Zwemmer. I'm connected to Thrive Amsterdam. And this is Thijs de Jong, working for Netwerk Kennissteden Nederland, an enthusiastic student.
We'll keep it as short as possible. We all know a lot has happened during last 2.5 years during Corona. Crazy times and mostly not good times, so to speak. What did we need? Quick shifting situations needed quick solutions. Well, who could do that? Students are very flexible, and we will provide some examples of that. And our main challenge right now is how can we find a balance between swiftly projects of students and the continuity and structure of public organizations. One of those solutions is a student civil servant. Teun is one in Amsterdam, and he will explain what he does and what his activities are locally. I will talk shortly about how we connect all these and exchange knowledge in the Netherlands. And well, since it works rather well in the Netherlands, why not scale up to Europe and what is needed to achieve that?
Yes, so I will briefly touch upon the student civil servant in Amsterdam. I will explain what it is, what it means in Amsterdam, and also touch upon like the impact it has already created. So it was established by Thrive, my role as a student and working for students in Amsterdam. Thrive Amsterdam is a social movement fostering mental health and using a preventive approach. Here in Amsterdam, the City of Amsterdam and the local health authority are the main financial contributors. You can see on the screen that the numbers of student well-being and actually the mental health problems are rising. Currently 56 or between 16 and 16 until 25 years old are experiencing moderate mental health problems. So that was actually a reason to create a student civil servant in Amsterdam. At the same time, there were already other student civil servants working across the Netherlands. I'm focusing on 3 particular subjects. For of course, mental health. I'm fostering mental health with students. Instead of working for students, I make it discussable. I present a lot of information, and I also provide low threshold services for students and student associations. Concerning the network, I am connecting the student organizations, the educational institutions, and the municipality with each other to build bridges and to minimize the gap between them. For example, when a student wants to create an event, I connect them with the subsidy department of the City of Amsterdam, for example. Finally, I'm also involved in policy making. I am involved in policy creation, such as targeting, or actually plans targeting young people and students, or strategic plans. How am I doing this? Well, I work together with multiple partners. You can see a few on the screen. And the impact I have done so far is, well, divided in several activities. For example, the study room service, this was created during the lockdown in 2020. And we created the opportunity for students to work in an empty hotel. And more than 1,500 students took part in this event. Besides that, I also created a campaign with several partners, and it reached out to approximately 7,000 students across the city. Third one I would like to mention is that all study associations in Amsterdam do have trusted persons where students can reach out. And finally, almost all higher education institutions in Amsterdam use the program which is called Caring Universities in order to get statistics in what's happening concerning student well-being in Amsterdam.
Like Felix said, an integral organization is very important because mental health is very broad. Teun is a great example for how to integrate students inside the municipality, etc. in Amsterdam. But why not expand it and exchange knowledge? Because what can we do? Well, one example is we create dashboards. So Felix creates documents which reveal 1 year later how everything is, what the well-being is, and we see it in 3 days. We give all the data so we can adjust and make projects. There are 10 student civil servants in 7 cities right now, and we also did online meetings with 4 Belgian cities in the lockdown period of Corona, and we noticed it really helped. The main question is thus, how can we expand and what do we need to expand? I see someone appearing, so we don't have time anymore. We need ambassadors and structural support, evidently. But the most important thing is somebody maybe feels addressed like, how can we reach people inside the European Union? We're just 2 students and it's very complicated for us. We know it works and we want to scale up, but we don't know how.
So yes, we are wrapping up. Many thanks for your attention and much appreciated. If you would like to reach out, our contact details on the screen. Yes, and thank you for your attention today.
Thank you very much, and well done for the great work in the Netherlands, both you with this specific drive action and also the work that the Trimbos Institute does. I would like to remind to our attendees that if you do have questions about this good practice, please do write it in the chat so that we can pick them up afterwards for the Q&A session. The second lessons learned that we would like to approach is about tailored actions addressing the needs of vulnerable groups. And a good practice specific to this lesson learned is about mental health promotion for refugee women. And I would like to give now the floor then to Sabine Kampmüller, Managing Director of AFIA.
Thank you very much. Yeah, I'm pleased to present the lessons we've learned from our health promotion program for refugee women in Vienna. I'm running an organization called AFIA. We are a non-profit and we founded AFIA 5 years ago in order to support traumatized refugee children. And our observation then was already that this group, refugees and migrants, are very little connected to existing mental health services and support. So we are really trying to address a very low threshold programs in order to reach this population. So we, next, we know from the group of refugees in Austria that there are high levels of post-migration stress, and from international studies we also see that about 1/3 suffers from post-traumatic stress disorder. And as I said, there's little connection to existing services. So with the first lockdown, we saw a large re-traumatization because of the re-experience of crisis situation, of panic buying, of curfew lockdowns. We saw levels of anxiety increasing or anxiety conditions reoccurring, partly linked to fears of the disease, but very much also linked to fears of being punished when not respecting the very strict COVID measures in Austria. There was an experience of discrimination also towards certain population groups. And as was said before, obviously we know that the burden of lockdown and particularly of homeschooling was high for parents, for mothers who were not in a good position to support the children at home, who were living in very tense conditions with little room to spread out, and who suffered themselves from even more isolation, from not being able to attend language courses, integration courses, and all of that. So we could see the existing vulnerabilities deepen here, but I would also like to say that we saw different coping mechanisms and capacities in this group. So we had already developed the basic concept of health circles in AFIA, which exists of a threefold approach. One is that there are lots of practical exercises and techniques to build mental health literacy and knowledge that is linked to the input from a mental health promoter. And very important is also the exchange in a peer group, the exchange with people, mainly women, in similar situations. The mental health promoters all have refugee backgrounds, so the groups take place in first languages, in native languages. And I'll come back to that later, why that is very important. So we adjusted that concept actually in the first week of the first lockdown in March 2020 to be able to conduct it in an online setting. We conducted these groups through WhatsApp, and they soon increased the number of participants who could actually take part. So we had 3 to 6 women participating in a very regular format, 2 weeks per hour, 2 hours per week, and over 8 weeks. And overall, in the first 1.5 years, we reached over 300 women from different groups coming from Syria, Afghanistan, Chechnya, Somalia. Yeah. So I'm showing you that very rough sketch because it represents a key learning for us. We conducted an evaluation 1 year after we started the intervention, and we saw that what the groups do is exactly creating a sense of coherence among participants that is so important for the logic of salutogenesis. As many of you who are familiar with health promotion know, this is what we understand is needed for people to actually change habits and change their mental health settings also. So the fact that we have the native language increases and enables comprehensibility of messages. The fact that people meet over a certain period of time and practice and re-practice increases manageability. So women actually understand they can do something. And the being in a group increases meaningfulness and actually helps to put worries and thoughts into place and creates a sense of coping. So this is actually the outcome of an evaluation that describes very strongly how this actually works. What we have learned is that the role of peer mental health promoters is key, because obviously language, but it's much more than that. There is a deep understanding of context that creates trust and helps women to open up and actually share, and in that sense also take on much more from a group. The second point is that the online format changed access and accessibility. We saw that we could reach women whom we would not have reached before, because they might not leave the house because of childcare duties. They might not leave the house because their husbands don't want to, or they may live far from the city center. So they were actually able to participate online. And while we prefer the offline setting, and we've gone back to it now, we still always keep online groups as well for women who benefit from that advantage. Our third lesson is how important it is for us on this very low level and being the first contact often for marginalized women, for us to have strong networks where we can refer women for other kind of support. So obviously, even if we want to talk about mental health, all the interlinked social and health issues come up during our health circles. And we have meanwhile built a strong network in order to be able to send people on for adequate support. Yes, where are we now? We've just extended the health circles also for Ukrainian women in Vienna. We have struggled to finance this program. It has been financed by the Ministry of Health, and we could negotiate continuation after we received the EU Health Award in May. So, but still, we believe this needs a longer-term solution if we want to make it an integral part of services, and we hope that one day it can be financed by the health insurance, actually. And we see very good chances to replicate that model, because even for Ukrainian women, where we have the difficulty to nostrificate and accept education of psychologists, for example, we can use this staff in health promotion because that's non-regulated. In a world where we all have human resource constraints in the general field of health, among the groups and for peer staff, there's a lot of potential, and we also see that our colleagues come with a lot of experience, and also they have difficulties to enter the labor market. They are very well placed in our work. And linked to that, we believe that there should be more visibility and regard actually for migrant health workers, because what they do can hardly be done by anyone else.
Thank you very much, Sabine.
Thank you.
I think that the time is up, but that was again another example of very good work done in the field. Please, again, if you have any question for Sabine, do write them in the chat. And we are now moving to the third area, which is meeting diverse and increased needs, ensuring sufficient capacity and quality within mental health services. And for this, I would like to give the floor to Matej Vinko from the Slovenian National Public Health Institute that will talk about the Slovenian experience. Thank you.
Thank you. Hello, everyone. So yeah, I come from the National Institute of Public Health of Slovenia, where I'm the deputy head of the National Mental Health Program that we have running currently. And actually, at the start of the pandemic, I was also tasked to prepare and then coordinate the implementation of the action plan for psychological support in times of COVID. So I'm going to briefly present some of the lessons learned, in particularly related to the mental health services in Slovenia in the past couple of years. Now, hopefully, I will be brief enough to allow for some questions and answers afterwards. So I'll start right away with the challenges that we were facing during the whole time of the pandemic, basically. So right from the bat, we had strong calls for action from clinical professionals that really quickly realized there is a surge in demand right after the lockdowns happened. And that is very nicely presented in this e-referrals data for first psychiatric appointments in Slovenia, where you can see the lines for pediatric referrals and adult referrals. And you can see the dips during the lockdowns, and especially for the pediatric population, large increases in the indexed values after the lockdowns. And yeah, that corresponded very well with the reports we had from the physicians, from the psychiatrists, clinical psychologists. And on top of that, of course, we already started to receive a large number of data from surveys of various quality, of course, that showed some substantial increases in mental health issues. Now, of course, time to act was, as soon as the COVID started, and from the beginning, the data was not of perfect quality, but seeing the reports and acknowledging, all the possible ramifications of not acting, of course, we started acting as soon as we noticed what was happening. But the responses that were specific to mental health services, more particularly to healthcare services, really lagged a little bit. Quite honestly, during the first year, it was the period of the gathering the data and preparing the proposals for the new services, for the improvements. And from July 2021 onwards, we really saw some major steps being taken. And that is what I'm going to present now. So I've separated the responses into two groups, the policy level and service provision level. And the policy level, we saw the establishment of Mental Health Council that was on the governmental level, and the Minister of Health himself was coordinating this council, was presiding the council, and it is an important stepping stone in the implementation of the whole national mental health program as well. So something that we have not been successful in establishing since 2018, when the national mental health program started, was triggered, if I may say so, by the COVID pandemic and was established in July 2021. So an important advancement in that on that level. And then secondly, action plan for the mental health program as well. After not being accepted in the end of 2021, it finally got accepted in 2022. So, now we have dedicated funds, specified actions to be taken in the whole field of mental health, of course, specifically addressing many of the issues that arose during the COVID pandemic. Now, for the service provision level, we saw most responses that were focused either on the child and adolescent population or strengthening our primary healthcare level. Now here, the inpatient services, of course, were mainly focused on the child and adolescent population, and we saw additional teams for outpatient clinics at the University Clinical Centers in Slovenia. We have 2 of those. And then we also saw some additional increase in hospital beds capacities. And that was a direct response to the needs that were reported by the service providers themselves. And then on the outpatient service level, as I mentioned, additional teams for child and adolescent population, but then perhaps more important for the long term, we also saw additional funds for community mental health centers. With the National Mental Health Program, we have started establishing a network of community mental health centers that are placed on the primary healthcare level, bringing services closer to the population. And during the COVID, of course, we saw more funds coming in from that direction. And then secondly, additional funding was secured for clinical psychologist training, because the reality is that even though we can secure funds, we cannot really secure professionals quickly enough. And that's the major issue in establishing new services, at least in Slovenia, I believe in many other countries as well. So more funds for clinical psychologist trainings were extremely welcome, because this was the area or the profession that had most problems in securing a systemic source of funding for their training. So those were the most significant responses in terms of mental health services within healthcare. And of course, it's not the whole picture. But then again, we can draw some conclusions from that experience alone as well. Strong political support proved to be crucial for relatively fast or faster implementation of measures we were lucky enough to have strong political support from the beginning of the pandemic, and then the government changed, and now we continue to have strong political support. So that's a very positive outlook for the future of our national mental health program, and the really responding to the needs that among the population. And then secondly, that without existing infrastructure or resources, that also might be, skills and capacities of service providers, new measures can really fall flat. So it is possible, of course, to build something from the ground, but when speed is really paramount, when you need to react quickly, it is crucial that you already have good enough infrastructure on which you can build on. And that was the case in our primary healthcare, where we couldn't imagine to establish more than 20 community mental health centers in a matter of a couple of years without existing community healthcare centers that are already present in Slovenia, that most of them already have some of the professionals that are in the teams of community mental health centers now already employed. So those are the two main conclusions from my side, and then always is a but, of course. The pandemic was just, the stone that caused the ripples, as Lydia also highlighted, especially in the field of suicide prevention. Much more can still develop, and it is the case for mental health in general. So even though I presented only the services in the healthcare field, much more was done. Unfortunately, we don't have enough time to present all of that now. But much more, in my personal opinion, should be done also to try to address the root causes. We always try to do that, but that's the most challenging field of work, and I believe, there's room for improvement, definitely. And with this, I'm ending my short presentation. If you want to hear more about our experiences, you can find my contact information on the slide. And thank you for the opportunity to present this today.
Thank you very much, Matej, and also to conclude mentioning what we call the social determinants also of mental health, which indeed need to be addressed. So we now have 8 minutes for question and answers for the speakers that we have heard until now, before proceeding then to our looking ahead final session. I have a few questions, and I will prepare. So there are 2 questions it's a question about sustainability, both for Theon and Thijs, and for Sabine, which is basically in terms of the sustainability, what would you need? What do you think that could help you keep going on with this good practice? For Matej, it is more about transferring a good practice. So do you think that what you have done could be transferred to other countries? And do you have like 2 top tips? And then there was also a question. I saw that Lydia was quite active in answering questions in the chat. Maybe I'll pick up one of them, and it is basically whether you have seen, WHO has seen any difference in terms of mental health impact, comparing countries that had more or less strict how do you say, like confinements
containment measures, yes.
Yeah. So do you want to start?
Claudia, with me. Thank you very much for the question, actually. And as I responded to the chat, there is not yet abundant evidence, but the evidence suggests that those countries you will have seen in the chat, and those are countries that capture, for instance, Sweden, that was not very fast into imposing lockdowns, and even when they imposed some public health measures, they were not the real lockdowns that many other countries have experienced. But you will see that, however, there is a considerable proportion of the surveyed segments of the population that refer to having been affected and having experienced mental distress. Now, the figures are questionable because you'll see, for instance, Sweden is comparable to Norway, but Norway was more strict into imposing lockdowns than Sweden. So I think we'll have to have a more longitudinal approach into understanding and capturing the real size of the impacts, because I don't think as figures are now, the figures we have now allow us to make a thorough, truthful interpretation. We'll probably need to see it on a longer terms. What are the longer terms? What evidence is there on the longer terms impact? So this is as good as I can get. I hope everybody has been able to see my answers to the chat, and there are also links to which participants can dig into and see for themselves. I hope I answered.
Thank you very much, Ledia. Yes, and I also would like to tell participants that we will collect the information that Ledia has shared so that you can access it and it will be available on the health policy platform. And also, if you have other questions, because we won't have a lot of time now to answer, do write them. Those that remain unanswered, we will address them to the speakers after the event, and then we will make information available once again on the EU health policy platform. So I see now Thais and Phil, do you want to answer the question about sustainability and?
Yeah, sure. We thought it was mainly the sustainability and how to sustain everything on the longer period. It's a broad question, and I think we summed it up quite briefly with the ambassadors, but it's kind of vague. We just need someone or a team or person who can help us in coordinating it centrally, like EU-wide. But our main priority and good thing that we have, or advantage, is that we can spread quickly because it's all local. Student civil servant is local. So the necessity is such a team or a person that we can speak with, and like if we can send an email tomorrow, we have time, we can start. And what helps us is if, for example, Mr. Vinko is like national people who kind of have the same goals, and he says we need an infrastructure. We are kind of that infrastructure, and we can set it down and like connect top down, bottom up. So mainly some enthusiasm from some people and someone we can connect with are the first steps in sustaining the momentum that we have right now. Right, Teun?
Absolutely, yeah.
Short answer, sorry.
Okay. Thank you very much. No, but it's very good because we don't have a lot of time. So you've been really, really good. Sabine.
Yes. Well, we believe this can be sustainable, using peers in health promotion, and we have developed a curriculum that could easily be replicated. That's actually our next goal, to roll it out to different regions of Austria, and very happily also to other countries in Europe if there is interest. It's very feasible. I think that is needed is someone with an interest in intercultural health issues and the attention to the need for training and supporting, guiding peer mental health promoters. And yeah, maybe the other point is the question, how do we link it to existing services? Because I think if there was something like prescribing health promotion, that would on one hand facilitate the financing, but also make it more known and accepted, that could be a next step.
Fantastic. Thank you very much, Sabine. And now, Matej.
Sorry, was the question on that I answered?
Yes, it was about transferability, basically. If you think that this is something that is transferable, and if you have some two top tips for countries that would like to follow the same path.
Yeah. I think the two tips are, yeah, basically build on existing infrastructure. That's the most important tip. But then again, also make sure that you have personnel to really include in those new services, either transferred from other services that are maybe not as necessary at the moment, or yeah, out in the market, so to speak. So what we did, for example, we established a helpline when all the services were basically during the first lockdown canceled. So there was no accessibility for person-in-person contact. And we took the health educators from the health promotion centers that have already received training on psychosocial counseling, and we included them in the helpline. So that's something where we kind of used existing resources and quickly shifted them to a new task that they, first of all, were competent of providing. And yeah, but that was just this, that was all made possible because we already had all of this in system, just that they were used to provide those services in person. And now that the office hour were done, they could not provide that in person. We managed to establish a helpline, which was also, I would call, a success story. So I hope that helps.
Thank you, for sure. So infrastructures, but infrastructures that have the flexibility to allow you to make these fast changes. So thank you very much to all of our speakers. And now we're moving towards the last session of today's event, which is looking ahead. So I would like now to then give the floor to Neris Edmonds from Public Health Wales.
Thank you. Thanks very much. And thank you for inviting me to contribute to the event today. So I work for the Wales Health Impact Assessment Support Unit. We're a small support unit within Public Health Wales. And I'm going to be talking about the mental wellbeing impacts and how mental wellbeing impact assessment can be used to help mitigate the impact of future crises on mental health. So I'm going to give you a brief introduction to mental wellbeing impact assessment and how it's been applied in both the COVID-19 and other emergencies, and an introduction to the tools and resources and different options for how they could be applied within future crises, and then pick out a few points for learning for the future. So mental wellbeing impact assessment is a health impact assessment tool, and it's designed to assess the impacts of policy, service, or individual projects on mental wellbeing of different groups in the population. And it's based on a framework of the factors that promote and protect mental wellbeing. So it has a preventative focus, and the structure of the assessment is around 3 core protective factors, which include enhancing control, building resilience and community assets, and facilitating participation and inclusion. The assessment also focuses on the social determinants of mental health and wellbeing, such as education, housing, economic security, and the physical and built environment. And part of the process also enables you to identify population groups who, first of all, may have a pre-existing vulnerability to poor mental health, and so may be particularly adversely affected, or they may actually benefit more from a particular policy or intervention. But what it can enable you to do is undertake an assessment of who in the population may be particularly vulnerable during a crisis or the implementation of a health protection measure, and consider how their needs need to be met. So MWIA is a decision support tool, and I think listening to some of the themes from today in terms of enabling a living and working environment for positive mental health and tailored action for vulnerable groups during crises, I think it's got a lot of relevance, as well as helping embed mental health and wellbeing into emergency planning. A little bit of background to the tool. It was developed in England in the early 2000s, and over almost a decade it was extensively tested and applied with a wide range of population groups and settings. It's also been used internationally in Europe, the Americas and Australia. And it's a tool really to integrate mental health and wellbeing into all policies. And in the context of crises, that may be emergency planning and designing particular measures or interventions in an emergency. It The process of the assessment can enable participation of stakeholders, including directly with populations affected, in identifying priorities for action. Also important is that it does identify potential ways to strengthen or opportunities for mental well-being, as well as identifying where there may be risks. And it should help target and recommend actions to maximise positive protective impacts, but also prevent or mitigate negative impacts. Mental wellbeing impact assessment has been identified by a number of organisations as a tool for strengthening the policy responses to population mental health. And it is a flexible tool, so it can be used prospectively in the design phase of a policy. And I think this is what's really important in terms of unprecedented or emergency situations where, as with COVID, we were facing a situation where we didn't have a strong evidence base to base exactly what, to anticipate what the extent of impacts would be at the beginning. So it can enable that prospective assessment to try and anticipate what those impacts might be and anticipate what population groups may be particularly at risk. But it can also be used concurrently whilst an interventional policy is being implemented and retrospectively as a learning tool. It can be applied at scale, different scales to small projects, local, but also national policy. And there's also a variety of applications. So it can be a desktop assessment that can be applied very rapidly. You can do it in more depth, gathering more evidence through participatory or comprehensive assessment. I wanted to give us some examples of how mental wellbeing impact assessments have been applied during COVID-19. So we're aware of a rapid mental wellbeing impact assessment that was conducted in London, and this was in a borough, a single local authority, where they wanted to really inform their community action and identify the high risk groups, and enabled them to develop a rapid plan to look at how they could mitigate mental health impacts in a particular local area. It's also been used on a number of different workforce scenarios, and I think going back to our first presentation, we're aware of how healthcare staff and other key workforces have been negatively impacted on mental health and well-being. So there's a couple of examples of where mental well-being impact assessment's been used to look at how staff have been impacted by digital and remote working, but also by then transitioning back into the workplace after lockdowns. It was also used on a hotel quarantine in Australia, where a number of staff were having to undertake a very different role to their usual role, and enabled that hotel quarantine, the kind of leaders of that service, to put in place quite a rapid set of actions to mitigate the additional stress on the staff. And finally, my own work in Wales has been a comprehensive assessment using mental wellbeing impact assessment to look at the impacts on young people's mental wellbeing in Wales. And that's been a more detailed assessment that we published in July. Mental wellbeing impact assessment's also been applied in other emergencies. It was used retrospectively to understand assets and factors in a community that help build resilience post-disaster. And it's my colleague Tony Coggins is using it currently with an NGO operating in Ukraine to look at kind of immediate actions to try and protect the mental well-being of staff who are working in Ukraine at the moment. So moving on to the tools that are available for people to use, there's a comprehensive toolkit for how to carry out a mental wellbeing impact assessment and the evidence base that sits underneath it. That was published in 2011. I'm one of the co-authors, and it was published by a collaborative in England representing a number of organisations. Within the toolkit, there's a range of tools going from a checklist tool, which is a very rapid way to undertake an assessment, to a more detailed desktop screening, all the way to more detailed workshop engagement materials. And one of the things we did with the work that I led on looking at the impact of the pandemic on young people in Wales was to adapt our workshop methodology to use online. So we actually conducted 3 focus groups online with young people and 4 focus groups online with teachers, using the mental wellbeing impact assessment framework to get some really direct experience from them. So moving on, looking ahead, mental wellbeing impact assessment can be applied to rapidly understand and respond to possible impacts on mental wellbeing during crises and emergencies and identify populations at risk. And this can help inform both the design of policies but also mitigations. It has a preventative focus and it's looking at how we can strengthen both individual and community level. It focuses on practical actions and the assets available. And I think I was interested about hearing about the student role in the Netherlands, because I think that highlights that we've got people as assets in communities that can be mobilised. It's a tried and tested toolkit and it's already developed and readily accessible. So if you want to know more, I've put a number of links in my presentation there, and my email if you'd like to find out more. Thank you. Thanks very much.
Thank you very much. And at the end, we're going to have another presentation, and then we should have a few minutes left in case anyone has a question for Neris or for our next speaker. So I would like now to give the floor to Quiva Nikavoid, apologies for the pronunciation, from UNICEF.
Thank you very much, Claudia. So hello, everyone. My name is Quiva. I work with UNICEF headquarters as a mental health and psychosocial support specialist. And my work focuses on humanitarian emergencies globally. So that includes things like public health emergencies, like COVID-19, but also other types of emergencies like natural disasters and armed conflicts. And as part of this session on looking forward, I'm going to highlight some global work that focuses on minimum response activities to protect and promote mental health in emergencies, focusing both on public health emergencies, like I said, but also learning from other kinds of emergencies. And I'll also talk a little bit about integrating mental health and psychosocial support into emergency preparedness and disaster risk reduction. So I think that's a theme that's come up a few times already. And really, I'll just try and highlight some tools that might be relevant and useful to your work going forward. So starting with the Mental Health and Psychosocial Support Minimum Service Package, which is a bit of a mouthful, so we say the MHPSS MSP for short. This is a set of 22 activities that are considered to be of the highest priority in meeting people's mental health and psychosocial support needs in an emergency. So the package was originally developed by UNICEF and WHO in collaboration with UNHCR and UNFPA, but the process involved gathering input from a wide range of experts in different sectors, and of course drawing on existing research and evidence-based guidelines. So it included a lot of content that was developed in response to the COVID pandemic, but also a lot of learning from other emergencies, including public health emergencies like Ebola and SARS, but also natural disasters and armed conflicts. So the idea behind the MSP is that when an emergency happens, we don't need to start from scratch. We already have quite a lot of knowledge and evidence from emergencies around the world, and this can be used in preparedness as well as response. The minimum service package is intersectoral, meaning it incorporates activities that are typically delivered by health actors, social welfare actors, protection actors, education, and others. And by combining this wide range of different types of activities into a single framework, it can help create a sort of a shared understanding and a common language when it comes to planning and implementing an MHPSS response. And so this can help people like policymakers, emergency response coordinators, and service providers to prioritize what needs to be done, and ultimately to help them move faster in a more effective and better coordinated way. So the image here on the screen is of the printable version, but the package is available as an interactive web platform at the address there in several different languages. So what does it all look like? Well, the activities are organised into 4 sections. Section 1 focuses on interagency coordination and assessment. Section 2 lists essential components of all MHPSS programmes. So this includes things like developing systems for staff well-being, for people delivering the MHPSS programmes, systems for supervision, and systems for monitoring and evaluation. And then section 3 contains the programmatic activities. So this is the main bulk of it, and it covers everything from community-wide messaging on coping strategies, common stress reactions, supporting children in distress, right the way up to, through things like community self-help and structured community activities, arts-based approaches, for example, peer support, and right the way up to focused support like psychological interventions for specific mental health conditions. And finally, section 4 contains activities focused on specific settings, including infectious disease outbreaks. So as you can possibly just about see in the little picture on the left, each activity is tagged or labeled with a range of coloured icons, and these represent the different sectors that are typically well placed to deliver each of those activities. So there's a little icon for health, for education, social protection, etc. Each of the 22 activities comes with a brief introduction explaining why the activity is important, a checklist of actions to help implement the activity safely and effectively, and a list of key guidelines, standards, and tools, things like curricula and manuals, to actually support with the planning and implementation. So the package is designed to be applicable to all emergencies, but of course, activities might require adaptation when there are physical distancing restrictions or travel restrictions in place. And so on the web platform, there is a section dedicated to this that outlines minimum actions that are specific to public health emergencies. Also guidance on how to adapt each of the 22 MSP activities to public health emergencies, and also again links to the existing standards and tools that are out there to help you do that. So I just wanted to mention a couple of examples of remote activities that were developed in the COVID era. The first one on the left here is the Health Buddy Plus app. And this is an app that was developed by UNICEF and WHO regional offices in Europe during the pandemic. So the idea is to provide evidence-based information in a really accessible way. So the app includes a chatbot that you can engage with to get advice on various things, including mental health and psychosocial support. So the image here is of one of the chat flows that caregivers can use to get tips on supporting their children during emergencies. The second example is also a chatbot, and this one is part of a much broader youth engagement initiative from UNICEF called YouReport. And this one specifically focuses, or it targets youth and adolescents, and it's accessible through Facebook Messenger, Viber, WhatsApp, those kind of platforms. And basically adolescents can use it to get reliable information on things like mental health, coping with loneliness, how to help others, and many other topics. The next one is, it's a prototype actually of a virtual safe space for women and girls. So in regular emergencies, it's very common to set up safe spaces for women and girls, which are used to discuss and address gender-related challenges. So obviously when there's an infectious disease, we can't gather people in groups like that necessarily. So this is a prototype, basically a virtual equivalent to that UNICEF is piloting, and it can cover some of the same functions. So there's a lot of interactive information on self-help, supporting others, gender-based violence, sanitary hygiene during pandemics, and that sort of thing. And finally, the one on the far right is the Peruk.me website, which is a collaboration between UNICEF and the Ukrainian government, as well as the Ukrainian Institute of Cognitive Behavioral Therapy and a few other local NGOs. And this is a platform for online psychological support groups for teenagers and parents. So it's a secure platform where sessions are run by, professional psychologists, and it can be accessed by adolescents and caregivers in Ukraine, but also those that have been displaced to surrounding countries and those that are still on the move. And I think that's kind of one important takeaway, is that a lot of technologies that were developed during the COVID pandemic to facilitate remote work are actually proving to be very useful in other contexts. For example, where people are on the move due to an emergency and not able to attend, weekly appointments in the same place, but also for people living in areas that we can't access due to security reasons. here are a couple of examples of self-guided help. Oh, I see Claudia has appeared, so I'll skip through this one. You can look at it on the slides later. But in my last minute, I just wanted to flag, that traditionally the field of MHPSS, as we call it in the humanitarian world, traditionally it's been focused on emergency response and recovery, but we're seeing a shift to a much greater emphasis on proactive preparedness and risk reduction rather than just reacting once a crisis hits. And part of that is understanding the difference between MHPSS in emergencies and regular mental health services when it's business as usual. And there are differences in terms of both what activities are feasible, but also in terms of how people cope when it's a collective community experience of a distressing event relative, compared with a regular sort of individual experience. So I just wanted to highlight this technical note that was published last year by the IASC, which contains a lot of information on what we can do before an emergency happens and practical tools like checklists, tables of do's and don'ts, and case studies and lessons learned from other contexts in terms of preparedness. So that's been a very quick tour. I apologize for speaking so quickly, but I'm very happy to discuss more in question time or if anyone wants to get in touch. Thank you.
Thank you very much, Piva, for being so good at keeping in time. I know that all of you had a lot, of course, to talk about. Thank you also to really emphasize the fact that we need to start planning ahead and being proactive instead of reactive, which I think it's very important. There have been a few comments I see in the chat. Thanking you all for all the good contributions. Saying that it is urgent and important to invest on mental health and the resilience of the healthcare systems and mental health systems. People are concerned about whether some of the infrastructures mentioned by all of the speakers are still in place now that looks like countries are starting a bit to step back from the emergency of COVID, at least the most drastic measures. And then let me see if there is a question for you. Yeah, maybe, yes. So there is a question that about the fact that all of what we've talked about today has been prompted by COVID. But are there any obstacle? Can you see any obstacle in using or using these good practices also to be prepared for the next crisis? How do we ensure that we are prepared? Are there enough tools? If any of the speakers want to take this on or give an answer, we just have a couple of minutes. So I don't know if anyone has a...
I'm happy to jump in if nobody else is jumping at it. Yeah, so I think it's a really good question, and we've really learned from many emergencies that they can be opportunities to strengthen the system more broadly and to build back better. Things specifically in terms of MHPSS, I think preparedness can involve things like making sure mental health and psychosocial support are incorporated into disaster risk management plans in lots of different sectors. So that could be within health, within sanitation, within education policy, also training frontline workers in emergency services, so also teachers, anybody who's interacting with the community, making sure they have training in basic psychosocial support skills, making sure they understand common stress responses to emergencies, and that they know not to over-medicalize normal reactions to abnormal situations. Also incorporating MHPSS in emergency training into regular training for health workers and social care providers. So as part of their regular, degrees or training, that MHPSS in emergencies is specifically covered. And also things like rosters and networks can be established in advance. So rosters of trained personnel that can be mobilized then in emergency. So I think Mate mentioned something like that, people that were trained for other things can be mobilized, and those same skills can be used in a new way when there's an emergency. But also having a pre-planned coordination mechanism for mental health. So there is a network and a system in place that can be activated when there's an emergency, that there's already those connections between the relevant actors to get things up and running quickly once the emergency hits. So those are just some ideas.
Thank you very much, Viva. There is also a question for you, but we will share these questions with the speakers, whether you could share the website for the digital psychological support for Ukrainian adolescents. So if you can, if you want to share it in the chat, but also we will save the information and then make it available on the health policy platform. So we have 1 minute left. So I will just like to conclude this event. I would like to thank again all of the speakers. I think that they brought us very enriching speeches, and it was really interesting to hear both about what we have learned, how this can be applied, and what good practices are there and are existing. I think that if anything, the COVID situation has shed a light on mental health, but mental health should not be forgotten when the COVID one day will be gone, or at least become endemic. The learning is really crucial to face a future crisis. Also those crises where people do not immediately think that they could impact mental health. So it is really key that we keep working together to be prepared for any future crisis and really to strengthen preparedness. All the presentations, including the contacts of the speakers, will be available after this event. The recording will be also available for 7 days on the platform, and afterwards the video will be accessible on the long term on Mental Health Europe's YouTube channel. There is also a library on the health policy platform, specifically in the group for COVID and mental health, to share resources. So please make use of it, because it is clear that we have a lot that we can learn from each other. So thank you very much again. And I hope to see you soon again in another EU mental health policy platform event.
Goodbye. Thank you.
Bye.
Thank you. Thank you.
Bye.
Thanks, everyone. Take care.
Bye. Thank you.